as other honors recognizing learners and faculty who've excelled in QUIP scholarship over the past year. The QUIP's consortium affiliate hospitals are listed here. It includes 7 hospital-affiliated programs, including University Health, St. Luke's, Children's Mercy, Center for Behavioral Medicine, Kansas City Veterans Affairs Medical Center, HCA Research Medical Center, and Mosaic Life Care. The QUIP's consortium mission follows. It is to lead in the scholarship and dissemination of local, regional, and national activities directed at enhancing quality improvement and patient safety initiatives. The goals of the QUIP's consortium also follow. First, the development of QUIP's curricula to support future clinical practice improvement efforts, and second, to expand infrastructure to facilitate collaboration, communication, scholarship development, and sharing that will improve quality and safety in the local and national healthcare community. The posters today are emblematic of the excellence that we're seeking to achieve in this space. I congratulate you all, and I thank you for your efforts. Each year, we bring in a highly esteemed expert guest making valuable contributions to their outstanding work in the field of healthcare quality and safety. You see before you a who's who of our past keynote speakers, culmination of which is today's speaker. With that, it is my honor to introduce you to Dr. Brian Wong. Dr. Wong is the director of CQUIPS, a staff general internist at Sunnybrook Health Sciences Center, associate professor of medicine at the University of Toronto, and division chief for general medicine. Dr. Wong received his MD and subsequent specialty training in general internal medicine at the University of Toronto. After completing his residency training in 2007, he undertook a research fellowship in patient safety, funded by the Canadian Health Services Research Foundation. He has co-led several major QI training programs at the University of Toronto, including the faculty resident co-learning curriculum, the certificate course in QUIPS and EQUIP, and he has worked with academic departments at the University of Toronto to establish criteria to recognize quality improvement and patient safety activities for the purpose of academic promotion. Outside of Toronto, Dr. Wong has worked with several national and international organizations, including the Royal College of Physicians and Surgeons of Canada, Choosing Wisely Canada, the Canadian Patient Safety Institute, the Association of American Medical Colleges, and the Accreditation Council for Graduate Medical Education, in order to establish training programs and standards to build QI and patient safety capacity across the learning continuum. He is a systematic thinker who thinks of how sustainability is possible with QI programs. I feel very honored that Dr. Wong accepted our invitation to present our keynote address today. Dr. Wong, welcome to the UMKC School of Medicine, and I thank you for leading this important day for us.
Perfect. Thank you. Alrighty. Thank you very much for that very kind introduction and the real warm reception that I've received here in Kansas City. I want to thank Dr. Norbash, thank Dr. Reddy and Sari for really just the kind invitation to come, to spend the day with you, and also the Rayudu family. I hope to have a chance to spend some time with you this afternoon as well. And boy, I have to say, like the people that were listed ahead, it's a little bit intimidating, I have to say. And so hopefully I will have the opportunity to share with you some ideas, some thinking around how to supercharge the quality improvement work that you're doing. So I think with that, we'll have a presentation and we'll have some time for some questions and discussion. So the objectives are relatively modest in that we'll just talk about 3 superpowers that effective quality improvers draw upon. and really try to distinguish between the importance of both technical QI skills and non-technical skills. Some people might call them the soft skills, but as I'll talk about in a moment, there's nothing soft about soft skills. They're actually sometimes the most important things we can do to sort of introduce change into a complex system. Now, the caveat is none of these are all that secret. They're not that super. They're things that are very attainable, and they're largely a matter of personal opinion. So if you don't agree, then I'm happy to discuss these afterwards as well. The other thing I will say, as I was talking to Dr. Reddy, is that I was a little nervous because actually I see a lot of these abilities being exhibited in the work that was shared today. So it made me worried that I wasn't going to have much to teach you, because I saw examples of people doing the types of things that we want to be seeing in the projects. And I'll maybe point some of those out when I have a chance. But it was really nice to have been able to sit in on some of the poster presentations this morning. I'm really looking forward to the oral abstracts this afternoon. Just as an aside, you know, if you give a lot of presentations, the real challenge is finding good images. And I asked ChatGPT to make a superhero, a QI superhero, using the colors of my center. And so that's what it came up with. Not bad, eh? Not bad. So, okay. So I think superpower number one is intentionality. Intentionality, okay? And so interspersed, I've included a few examples. So some of you may have seen the movie The Martian. Okay, so that's Mark Watney. And so there will be a few spoilers, not too much. So you may remember he is stranded on Mars. He's got a limited food supply, and he's got to survive until someone can come and get him off of Mars. And so he figures he needs to take the small sort of supply of potatoes and multiply them by planting them and growing more new potatoes. But to do that, you need water, and there's no water on Mars. And so this is the scene where he's been trying to figure out how to generate water, and induces an explosion. And what does he say? He was stupid because he failed to account for the oxygen that he was breathing back out into the air in his calculations. And I think in many ways, quality improvement is just like if you're stranded on Mars and trying to solve a problem, which is that you have to pay attention to the details, right? Quality improvement's all about the details, and I saw that in the projects. People were talking about going into the environments, observing what was happening, really understanding what was going on. And so these are three ways that I think quality improvers do a really good job in paying attention to the details. They do this by not jumping to solutions, avoiding premature evaluation, and in their PDSA work, making predictions. And I'm going to talk about that in a few ways. So this is the audience participation part. So I'm going to ask you just with a show of hands, okay, and I'll be honest, there truly are no right answers, okay, so this is a safe environment. So we'll just put up your hands. So I'm going to ask you, you want to improve DVT, so like clot, hospital-acquired clots in your legs. You want to improve the prescribing of medications to prevent that from happening, right, in your hospital. So which intervention would you choose? Which do you think is going to be the most effective? So show of hands, how many of you would go towards implementing a checklist? Okay, so we've got a few hands. And I know some of you are on Zoom as well. I apologize, so maybe you'll have to just vote on, online there. Standardized order sets, so you actually write it into the order. Okay, a bunch of people. Educating your staff on the guidelines. Okay, one or two. Delegating this to a team member, like the clinical pharmacist. Okay? And how many of you are just not quite sure? A few. Okay. Some of you more than once. That's okay. All right. So then let's just hold that, in your mind. Skill testing question number 2. Patient arrives at the emergency department with difficulty breathing. Which treatment would you recommend? So let's start. How many of you think that we should prescribe a diuretic? A bronchodilator? Antibiotics? Anticoagulant? Unsure? Okay. Okay, so why, what am I trying to get? So why, let me ask you, are you so unsure about this situation, and yet here you seem pretty confident that actually a checklist or a standardized order set was the right answer, or was the right approach? Because what I would argue is that both situations require the same process, which is you have to understand why the problem exists before you can choose a solution, right? And yet, I think in quality improvement, we all have this tendency of just sort of feeling like we know the right answer a little bit more than sometimes we do in clinical medicine. But I would argue, and many of you are students here, that you're going to be taught you got to come up with a differential diagnosis, you got to gather some information through tests, physical exam, and then you come up with your treatment, okay? And so here's an example, right? So you have to be able to articulate that theory, and you have to have a really clear understanding of the problem. What is it that's driving the issue? What are the root causes of the problem that you're trying to solve? And then think about the solution. Here's a good example. I know there's some pediatricians or people working in pediatrics here. So we know that many people, many kids with otitis media, ear infections, don't really require antibiotics. Often it's a virus, and they'll get better. And yet we know that actually antibiotics are often overprescribed for this problem. Right? And so there have been many quality improvement projects aimed at trying to educate providers and make them aware of the guidelines, and maybe even putting posters up in the clinic, and so on and so forth. And they've largely not been that helpful. And why is that? So why do you think that is? Why do you think that, like, educating around the guidelines, why do you think that has had limited impact on overprescribing of antibiotics for otitis media? Okay, so maybe you're just like, you're having to constantly educate new people. That's one possibility. What else? Okay, and so tell me more about that. What do you mean by that?
It's the perception that antibiotics are necessary for this treatment, and families, pediatrician here, very upset when what their perception of the treatment is not fulfilled.
For sure, right? So it's what is the expectation or like the perception. And I'll tell you, every force is pushing for antibiotics. Kids not sleeping, they're irritable, they can't go to school, you're missing work, right? And so the motivation when you're coming and you're taking time off work to bring your kid into the office, so the motivation is to get the treatment that you need on that visit, right? And so I can be fully aware of the guidelines, and yet the pressures are going to be to maybe write that prescription because that's what is being asked of me, okay? Now, but if you understand that the root cause may be around family or parental satisfaction around this issue, and understand what is the sort of driving some of the request, you can design different types of interventions. So here's a different solution, which has been studied, actually, which is the provision of a delayed prescription. And so the idea here is that for kids that are not looking that sick, and clinically you're highly suspicious that they have a viral sort of etiology of their infection, you can prescribe antibiotics, but it's delayed by 48 hours. And the idea is you counsel the parents to say, if in 48 hours your child's still febrile, not doing well, and I'm not a pediatrician, by the way, I'm an internist, but I'm pretty sure this is what they say, yeah? Okay. I've got someone spot checking me here. And they said, then please go fill this antibiotic and then and give it to your child and call the office. But if they're better, fever's gone, they're back to their usual selves, just throw the script out. And this is a Cochrane review, numerous studies that have shown you give that prescription on day one and out the door, and they can fill it, 93% of the time it gets filled, right? But if you give it as a delayed prescription, only 29% of them get filled. Huge impact. And of the balancing measure, parental satisfaction, which we heard about was the big driver, no difference. Visits to the emerge, kids going to the ICU, no difference. The major difference, slightly longer duration of fever with a delayed prescription. And I think that makes sense because there are probably some kids that needed antibiotics that are being treated a little bit later. Okay? So that's an example of really understanding the problem before you choose your solution, okay? The second intentional act is around a fidelity, paying attention to fidelity. And actually, I have this example, but I don't need to use this example because I saw it this morning. I can't remember who presented, but someone presented on intraoperative hypothermia. Who presented on that? Okay, so the project was intraoperative hypothermia, and the outcome of interest was trying to reduce the rates of intraoperative hypothermia. And in order to do that, there were a number of process changes that needed to be introduced that were felt to help to reduce intraoperative hypothermia. And so what was really neat to see was that each one of those processes were being tracked alongside the outcome. Because you can't expect your outcome to improve if you haven't changed the underlying processes, right? And that's what fidelity is all about. If you're doing quality improvement, you have to understand what are the key ingredients, and you have to make sure that those processes are actually in place and happening to the extent that you're hoping that they are. Here's an example that was published. This is an early warning score, okay? Early warning scores, you probably have them in your places. A lot of hospitals are implementing them now, right, to detect early deterioration clinically. So the black dots are each time that early warning score was being triggered and activated for the staff. And this time scale, by the way, is quarterly data. So just so that you know, this is 7 years, okay? The quality improvement is not easy, okay? But when done well, can have a huge impact. And so you can see for about 4 years, there were huge attempts to try to get this new system working, and it was just not being taken up, not to the extent that you would see any impact on mortality. So why evaluate your impact on mortality when the thing that's supposed to reduce mortality isn't happening? And then you see this huge uptick. I have no idea what they did. They did something. They did a huge amount of work to get the early warning score activated and sent alerts to the providers. And then what you'll notice is that the white dots correspond to percent mortality on the y-axis, and that's, the average was around probably 7%. And you'll notice on that control chart, all those white dots now fall below the center line, right? That's special cause variation. They reduced mortality, but only when the early warning score was actually being used. What's really nice about this example, by the way, is we don't often have the luxury of doing randomized trials in quality improvement. But when you see a chart like this where the outcome measure shifts at the same time that your process measure shifts, it lends a lot of credibility to the claim that the change that you made actually led to the improvement. Okay? So people doing quality improvement, I really encourage you to think about fidelity. And then the last is this idea of authentic use of PDSA. And one thing that one thing that I was taught years ago was that PDSAs, think of them like little experiments, every single one of them. Okay? Just go all the way back to grade school when you learned about the importance of having a hypothesis that you were testing. And so we often use the term plan, do, study, act, but I would say it's about making a prediction. Every PDSA should have at least one prediction. I predict that if I lower the room temperature in the operating room, that this will have an impact on core temperature. But I also predict it might make it more uncomfortable for the operators, like the surgeons. So when I do my PDSA, now I know what I'm looking for. I'm going to actually talk to the surgeons and the nurses to see if they feel uncomfortable, and I'm going to check to see what the core temperature was to see if there was a difference. You don't make that prediction, you don't know where to look, right? So PDSA is about having this in your mind. What are the predictions what's the prediction, what's the hypothesis you're trying to test? And then what you can do is you can actually have a way of thinking about what are you hoping to learn from every PDSA cycle. And this was actually a nice commentary published by a couple colleagues that I work with. Can you identify some missing ingredients? Maybe you need to refine some of the components of the intervention. Maybe you've identified some barriers. And you have to think about that because this will all inform what you're going to look for in each PDSA. So here's an example of a project to reduce catheter-associated urinary tract infections using a medical directive. The idea being that if certain criteria were met, nurses no longer needed to wait for a physician order because they already would have a medical directive in place to remove the catheter. Okay? And it's been studied and it's been published, and this group, colleagues of mine, wanted to see if they could implement it locally. And so this was the algorithm that was in the published study that they were trying to emulate. And what my colleague did, which I thought was really nice, was use PDSA in a very clever way. So what he did was he used almost like in situ simulation. What he did was he created a whole bunch of cases, and he would just go to the units, the clinical units, and just ask if a couple nurses could sit down with him. And he would give them this sort of flow sheet, and then ask them to just go through the cases and say, you know, in this situation, do you think the catheter should stay in or come out? And if the decision was to leave it in when it should have come out, or take it out when it should have stayed in, he didn't, like, you know, wag his finger and say, you know, I can't believe you made a mistake. What he said was, help me understand, what was it about this that, you know, made you think that that was what you should do? Ah, okay, it was that step there. Could we have been more clear? Like, how could we make this more clear so that, you know, it's not, so that you wouldn't have misinterpreted it? And then they would sort of say, well, this is what we don't do it this way, we do it this way, and so on and so forth. And eventually, after 6 PDSA cycles, 6 representative end users, they came up with this different flow sheet. And it looks more complicated, but it is 100% reliable. They put it in front of a whole bunch of nurses, the same cases, and they got it right every single time. And the reality is that you want to do that before you go and release a tool into the system. We all know what it's like to work with, like, tools that have not been fully baked. It's frustrating. It just makes you not want to do it, right? Not only that, it was super engaging. The nurses felt like they had a hand in designing the tool that they were then going to use, right? So PDSA is actually a really great engagement strategy. And not only that, when they implemented this change, they reduced urinary tract infections. On the left-hand column, you'll see before the rate of urinary tract infections, and after, almost an 80% reduction. And on the control units where they hadn't yet implemented, there was no difference. And the balancing measure, of course, you're going to ask me because you're all quality improvement experts, there were no increases in reinsertion rates, which is always the concern, right, that we took a catheter out inadvertently. Okay, so now this all seems like you didn't need to bring me from Toronto to teach you basic quality improvement, but I will say that these same concepts that you've been learning about, you know, in your program, I just want to make sure that you understand that it's really important to get the details right. It makes a big difference between doing PDSA and doing PDSA effectively, is really just paying attention to the small details. But those are what I would argue are the technical skills of quality improvement. Process mapping, PDSA, run charts, okay? Which was, by the way, amazing to see so many run charts today, okay? Many curriculum that I am aware of don't get projects to the point of having run charts, so congratulations. But, you know, a colleague and I argued that actually there's nothing soft about the soft skills of quality improvement. Actually, that, you know, you can learn all of these technical skills, but the people that we know who are really effective have mastered the soft skills. I'll call them the non-technical skills. Okay, they're the skills that allow them to be able to engage others in the quality improvement work in a really meaningful way. And so the next skill that I will talk about is the art of persuasion. And what I would argue is that in order to be a really effective quality improver, we have to be able to engage others and persuade them to do a whole bunch of things that they're not planning to do. And it's not in a, like, conniving, evil, kind of nefarious kind of like I'm trying to persuade you, but more just trying to kind of help people meet you part way in the conversation kind of persuasion. Okay, and so they're almost like Jedi mind tricks, right? So for those of you who are aware of Star Wars, right? So there's Obi-Wan Kenobi, and the idea that he could sort of get people to think and do things that they maybe weren't planning to do. So I'm going to share with you 3 examples, and we're going to go through them very quickly. But these are examples that I've observed in others and tried to emulate myself in kind of the way that we try to engage with people when doing quality improvement work. So actually, it's helpful to go back even further than Obi-Wan to think about Aristotle's kind of thinking around persuasion and rhetoric, actually. And so what Aristotle proposes is that there are actually 3 modes of persuasion. There's ethos, which is drawing on credibility when you're trying to persuade someone. There's pathos or pathos, which is drawing on emotional elements, or logos, which is drawing on logic. Okay? So what might that look like if you were, say, leading a quality or safety project? It might look like this. The World Health Organization has identified safety as a global threat. Well, I mean, the World Health Organization, that's a credible organization. So of course, if they think this is important, I think it's important. Logos, preventable medical errors affect 1 in 10 patients in every hospital. You give them some data. And actually, we observed that in the second round. Someone, I don't think he's here right now, told a story during at the very end of his presentation about a single patient who, because they were not, did not get offered the treatment that he was trying to, this was a camprosate to reduce cravings for alcohol use disorder. This individual unfortunately died of liver failure. And he told that story as a way of trying to compel us in the audience to understand why his project goal was so important. That's pathos, emotion, okay? So you can, and the thing is that the people that are really good at this, they kind of figure out who their audience is and figure out how to lead, I hate to say it, like I'm in internal medicine, like all of my colleagues, they like the data. You gotta cite New England Journal, you gotta find some JAMA article, like you just kind of know, you have to know your audience a little bit, right? So they're gonna always ask about the evidence, like I just know my colleagues, right? And so if I go to them and say, some other organization, reputable organizations doing this, that's not gonna sway them. They wanna see the data, right? But you have to know, but my CEO, all I have to tell him is some other organization's doing it that's reputable, and he's all in, right? He's all in. So, okay. Another really nice, again, I'm just giving you these ideas because you might want to think about how you can incorporate this. This is Lorelei Lingard. Lorelei Lingard is a linguist. And she actually did a lot of the foundational work that ended up informing checklists in patient safety. Okay, by the way. She's a scholar out of London, Ontario, in Canada. And she writes about how to write. So if you ever want to provide your students or learners, or if you are students and learners yourselves want to learn how to write well, she's got this whole series of articles on how to write different parts of a manuscript. And this is the opening of a manuscript. And she says that there's this sort of heuristic of what's called the problem gap hook, which in linguistics is a really effective way of persuading people to come on side and engage in a conversation. And it basically goes like problem, describe the problem in your QI initiative, that your QI initiative seeks to address. What's the gap that exists, right, about the problem? And then you articulate the hook to draw them in. So this was an initiative I was involved with during the pandemic. Okay, avoidable transfers to this was during the pandemic when we were really concerned about long-term care residents coming to the hospital and then they couldn't go back to their long-term care homes because of quarantine reasons. And so in the end, what we wanted to do is try to provide more care in the home by doing outreach and providing virtual care. So this was a big project that we led during the pandemic. And so we needed to go around and convince people of this as an important program to support. Avoidable transfers to hospital expose long-term care residents to hospital-acquired complications, contribute to emergency room crowding, and increases cost to the system. The issue, though, is that the providers working in the long-term care setting don't have access, timely access, to the necessary resources to be able to provide care in place. Given the mounting concerns around the care experiences and outcomes of residents living in long-term care, and the increasing stresses faced by our acute care systems, we need an integrated care model right now to be put in place. Okay? It's what a lot of people talk about as an elevator pitch, right? And a lot of elevator pitches follow this problem gap hook heuristic. And the idea is, if you've watched the movie Inception, right? Inception is this movie where you're trying to get the person to actually feel like they came up with the idea themselves, is that a lot of times you really are trying to encourage people to feel like they had a hand in coming to the decision around whether to engage in the change that you're hoping to implement. And so actually this has been studied as well, and there are like literally hundreds of frameworks, so it's a little bit arbitrary which one I choose, but actually one of the ones that's been studied a lot in quality improvement is Rogers. Rogers' diffusion of innovation curve, and this whole idea that whenever there's a new change, there are the people that are like the real innovators and think of them like they're always the ones out getting the newest iPhone, for example, right? And then there's the whole bunch in the middle that kind of need to wait and see how it goes, and then there are the laggards that's like my parents. They have a flip phone still, and they're not ready to have the government looking in on their business banking on their phone, so they're not ready for that yet, right? And so Rogers actually has talked about how you can take people in that big middle section and sort of shift their thinking towards kind of being ready to take on or adopt a new innovation. Or what are the features of innovation that are more likely to be adopted? And so, I think you can actually leverage that understanding to think about how you can communicate around a change, okay, to make it appear as though it's one of these innovations that are ready for adoption. And so what are the types of innovations that are ready for adoption? They're ones that demonstrate an immediate advantage to the people experiencing the change. It's the what's in it for me kind of phenomenon, right? And actually, that's very different than observable benefit, which is what is the benefit that we will derive as a society from the change. And I think sometimes in quality improvement, we tend to jump to observable benefit a lot. Our patients will do better. Our system will do better, our community will do better. And let me be clear, I think that's really, really important. But I think that we have to be realistic in the fact that some people, yes, they'll be swayed by observable benefit. We all want to do the right thing, but we also need to know what's in it for us. It's just human nature. And I think if you ignore that, you ignore it at your peril, right? So that's the difference between immediate advantage versus observable benefit. And some of my colleagues will actually go so far as to say, start with immediate advantage, knowing that you're going to move towards observable benefit at some point. Compatibility is about how much does this change align with the way people are already doing things. The more compatible with your existing workflow, the more likely it's going to be adopted. How trialable is it? Okay, I mentioned this earlier. I was saying something about how you could test out automatic prescriptions if you wanted to, and you could turn it on and off, right? You can try it out. You don't, 30-day trial, you can cancel any time, right? You're much more likely to get someone to be willing to test it out if they know they can turn it off, okay? And then complexity. The simpler the change, the better. So if you go back to the urinary catheter example, this is what it would look like, okay? Immediate advantage. You know what? You can act right away. You don't have to wait for a physician's order to remove that catheter anymore. Observable benefit. Our patients will have fewer infections and less delirium, and they'll get out of bed sooner. Compatibility. This new protocol actually fits right into the change of shift nursing assessment. There are no extra steps. that we're asking of you. Trialability. But you know what? Try it your way. Test out what works for you. And then complexity. It's actually really simple. There are only 4 simple reasons to keep a catheter. Beyond that, you can take it out. Again, it's just about being intentional in how you communicate and thinking about what it is that you're trying to get people to kind of get their heads around. Okay? So, the art of persuasion, those are the 3 kind of frameworks that you might want to consider for your quality improvement quiver. Okay? And then the last is empathy. Okay, I think the most effective quality improvers demonstrate and exude empathy. Inside Out. I don't know how many of you have seen this movie. Yeah? So that's sadness and Bing Bong. Okay? And so if you remember this part of the movie, Bing Bong lost this wagon, which was a memory of a childhood wagon, and was very sad. And there's another character, Joy, who tries to cheer Bing Bong up, right? And then sadness comes over and listens and empathizes with Bing Bong and acknowledges the pain and the hurt of having lost this wagon. And so empathy is really about perspective taking, trying to take the perspective of others, to avoid judgment around how others may perceive or feel about things, to validate emotions that people may be experiencing, and expressing care. And I really like this because actually one of the OGs of quality improvement, Don Abedian, many of you will know Don Abedian as being the individual that came up with outcome process, structure outcome process measures, right? He actually had another phrase, which is that the secret of quality is love. Okay, the secret of quality is love. And I do think that, love for your patients and love for the system and love for kind of the effort that's required to make things better is kind of grounded in this concept of empathy. And so there are actually tools, I'm not going to go into them today, which actually allow quality improvement teams to actually empathize with the perspectives of others that are experiencing changes. This is an empathy map. This is used a lot in design thinking principles. But what this does is it allows teams to go around talking to different people experiencing the change so that they can start to think of, understand what are they hearing, what do they think and feel, what do they see, what are they saying and doing, what are their concerns and what are their needs. And the idea is that this is a structured way of being able to sort of try to draw upon empathy to gain perspectives of others. Empathy is also important, I would say, because in order to actually take quality improvement to the next level and make sure we're improving care for everyone in our society and taking equity-based approaches to quality improvement, we need to be able to work with and partner with people who are experiencing inequities, and that requires an empathic approach. So this was something we actually just published it a month ago. I'm happy to share with you, but this was a new framework. It was based on 40 published frameworks, so it took a long time to do this. We looked at 40 published frameworks and tried to identify what were the common elements and developed like a meta framework for how to incorporate and embed an equity-based approach into your quality improvement work. And the reason for that is that, yes, there are equity-focused projects. I'm going to talk about an equity-focused project in a moment. But many people argue that we need to be thinking about equity in all projects because what we often see is on the left-hand side where things improve, but the gap persists. But on the right-hand side, sometimes what happens, we make a change and actually the gap widens. We saw that in our local setting with telemedicine. Because what happened was people who had access to technology and high-speed internet and could take time off work and had a separate room in their home to be able to take a private appointment, they were able to leverage virtual medicine no problem. But then people living in high-rise apartments with bad internet and multi-generational families living in small spaces, they couldn't. They couldn't take advantage of that change. And so then all of a sudden we saw actually like cancer screening rates widen in terms of the disparities. And so if we take an equity-based approach, we both improve care and narrow disparities, okay? And so at the core of this framework, right at the middle, is that we need to engage with people who have lived and living experiences of inequities. And it means that we need to build trust, share power, and foster co-creation. And within each of the other wedges of that lens, there are subdomains that I'm not going to go through today because it's not really the focus of the presentation, but I would encourage you, if you're interested, to have a look because it provides some concrete suggestions for how you can define the equity problem within the AIM statement, to diversify your quality improvement team, and to examine the broader structural and social root causes to problems, to actually design your interventions to reduce inequities and then measure that impact. And at each one of these stages, there's the need to engage with people who have lived and living experiences. And we cannot do that unless we had developed the ability to empathize. Okay, we just cannot do that as a healthcare team. And so we actually partnered with a community panel who helped us to refine the framework and then produced this table in the paper, which I'm not going to go through in detail, but just to share with you, with some really concrete suggestions for how the community panel felt teams could engage meaningfully with communities. And I'm just going to end with an experience, a personal experience I was telling Dr. Reddy that I had, not as an organizer, but actually a participant about 2 weeks ago. This is an initiative happening at my hospital. The reason I was invited is because I co-lead an initiative around increasing the use of professional interpretation for people whose preferred language isn't English. I don't know what it is in Kansas City in terms of your percentages. In Toronto, where I am, 25 to 30% have a preferred language that's not English, and it's a huge list of languages that we have in Toronto because we're a very diverse community. What I wasn't aware of is that people who are deaf or hard of hearing have a preferred language as well, and it's not English, by the way. It's American Sign Language often. And so our quality improvement indicator for equity for our hospital for this upcoming year is to increase the use of ASL interpretation for people who are deaf who come to the hospital. And so this was actually drawn in the 4 hours during the co-creation workshop based on the conversation. It was amazing to watch, actually, this cartoonist do this. And so I really have to acknowledge the organizers. They were 3 medical students, by the way, okay, just so that you know, 3 medical students who went on a placement with a community organization for people who are deaf and hard of hearing. And those 3 medical students, with their faculty supervisor, then went on to partner with the executive director of the Silent Voice program, the director for equity social accountability, and then that Chilla, who's the professor who was overseeing the project. Now you might say they're residents now. Well, you know what? They did this as a second-year medical school placement, and even though the course was done, they were so committed, they worked on this for 3 years. And into their residency, they've continued to work on this initiative. And so the goal was to co-create more accessible, equitable, and inclusive experiences within healthcare with and for deaf people through education and quality improvement. And this is an image of the co-creation workshop. And the idea was that they wanted to embrace a strength-based human rights model that recognizes that being deaf is an asset, it's an identity, and it is a culture. And the reality is most of us in the room had no awareness of what it is to be deaf and what the experience of being in hospital as someone who is deaf is like. And so there were 85 people in attendance. At my table, there were 2 people who were deaf and in-person interpreter. And there were other people in the meeting who were in attendance. And the goal was to come up with ideas for changes that we could implement. Okay? And what I learned through those conversations were that reasons why people who are deaf have such negative health experiences and outcomes are rooted in how our systems are designed. They're just not designed for people who are deaf or hard of hearing. And these were some of the examples they shared. When you page overhead for someone, like one of the people said they sat in a waiting room for 2 hours not realizing their name was being called for an appointment. You know, in order to do ASL interpretation, you need a tablet with internet, and a lot of places still don't have enough equipment to be able to even offer that type of interpretation. Call bells, right? Call bells are activated, but then someone's speaking over the other end, so there's no way to actually alert. It's not easy for someone who's deaf to alert people. And then finally, a lot of our patient materials, what I didn't realize is that actually written language is not actually very easy for people who are deaf to read. A lot of their language skills are through ASL, and so actually in order to be able to provide patient materials, it actually is preferred to be done in ASL through video. But again, our systems just aren't designed. So we have to kind of think about how do we redesign our systems. So we're not there yet, right? This was just like a workshop. It was 2 weeks ago. But when in a 30-minute period, we had a chance to co-create all kinds of different ideas, which was amazing. Okay. And I will tell you that this was my experiential learning, which helped me to develop empathy, which was that at the start, I was sitting near the front, and after the first presentation, I started clapping. Okay. And I was like one of about 10 people, because the rest of the room was applauding the way that people who are deaf applaud. And by the end of the meeting, everyone was applauding by, you know, waving their hands. And it just made it very, very real for me what it is to be deaf and what that experience is like. Not because I am deaf, not because I could ever truly understand, but it's about perspective taking, right? And it's about having that transformative experience that you sometimes need to then be able to take that step towards making a difference. Oh. I might, but it was just the closing slide, so I don't think it's, that's okay. So the last slide was just to say, to summarize, we talked about intentionality, we talked about persuasion, we talked about empathy. And by no means are these the only things that you need. By no means am I saying that this is these are the only strategies you should be using. But I'm just hoping that that by providing you a range of different options, you might just be able to reflect on how you could adopt some of these ideas into the way you're, I'm sure, already doing work in this area. I just want to, again, thank you so much for the very warm reception I've received. I've really enjoyed what will be, unfortunately, a very brief amount of time I'll be in Kansas City, and I look forward to spending the rest of the day with you. Thank you very much.
Questions?
I'll ask one real quick. If you could comment from a training perspective about how you can effectively impart the technical skills versus the non-technical skills to trainees. So how can you encourage the learning, particularly of the non-technical skills?
I think some of it is probably through the short answer is I don't know. Actually, the commentary we wrote was to say that I think we figured out how to teach the technical skills, but we haven't quite figured out how to. So I think part of it is actually turning to some of our medical education, health professions education colleagues and sort of partnering with them and saying, like, if you need to teach communication, collaboration, leadership, empathy, what approaches do you tend to use? That might be one way to think about it, right? Because I think that I suspect that these teaching and learning around these skills are not unique to quality improvement. So that would be one thing to consider. I think the second is role modeling. I do think that a lot of what people learn and can they learn through observing how others, but then making it really explicit, right? And saying, look, like we're gonna do this because we want to make sure that people understand the rationale for why we're doing this. And that's all we're going to talk about today. We're not gonna try to get them to change their practice. We're just going to explain the rationale today, and that's it. So I think role modeling, and then I think the third is actually just calling it out, right? Like I think I will just reflect on our curriculum. We do not do a good job of emphasizing the non-technical skills in the actual curriculum. It all kind of gets downloaded to the project work, where I think it's pretty variable how it plays out.
Question. So I'm from University Health, the adjacent hospital you see next door. I'm interested in how you go about, how do you go about ensuring equity from the beginning? So we have an equity statement in our project charters for our continuous improvement projects, but I'm not sure we're doing a great job at nailing that statement and then measuring it. We have a ton of equity data and that sort of thing, but do you have any pointers on that?
I don't, only because I would say that I think I think everyone is trying to figure that piece out. I think that what we're hearing a lot is that I think there's general agreement that equity is a core aim of quality and that we need to be very, putting it front and center in the work that we do. But the actual equity-based approaches are underdeveloped, I think, in quality improvement. So much so that we're in our sort of affiliated hospitals, we're actually going to be launching a learning community for people who are trying to do this work to bring their examples together so we can learn from one another. One thing we've been doing is similar to you. We've started to embed the equity statements and equity prompts in different parts of our curriculum. And what we try to say is, look, you don't have, these are the range of options you can choose from. We know this is not easy. We know that you're, making an effort. Just pick one thing to do. Don't have to do them all. Just pick one thing. Maybe when you're designing your change, can you consider what one thing you might do to make sure that people who face unique barriers are attended to as well, for example? And I think one of the ways that I've been learning now is that, and again, it depends on whether your health system is equipped for this, are there people who are, patient family advisors or members of the community that are available to actually provide input on what are the projects that are really meaningful, right? Having them involved in the priority setting early on.
Thanks.
So I like and I think we've probably all felt that, as healthcare providers, we like to jump to, let's just start, patient rolls in the door, I already figured it out, right? All those diagnostic biases that we run into. Do you envision a way, as you mentioned in your intentionality, about premature evaluation and premature closure, do you think there's a way to take some of those skills around reducing diagnostic bias and then pulling that into some of the QI work? Do those align, or are they different?
I think there's some similarities. I think one of the things that should learn this from someone else is they have this exercise where they actually get their learners in quality improvement teams to actually defend their decision to implement a certain change. Like basically they actually have to go in front of a room of people and actually defend that this is the right change to be prioritizing. And what that forced those teams to do is to actually think through what's the rationale for why I think this change is going to work, right? And I think by that exercise really does force then people to then work backwards. And then usually what happens is you realize, actually, I don't know why this change was proposed. Or I don't actually know what particular kind of data informed our decision that this is what we were going to move ahead with. And unfortunately, I think, and again, there's a little bit of, I think the reality is that sometimes the best design changes are also really hard to implement. They require a lot of resources and they're not feasible. So I think sometimes it is okay that if you start by doing something that's feasible, to make that your first step. And the reality is actually education and training and awareness building is really critical to prime the pump. Because we all know if you start with a system change and people don't know what's going on, they'll just work around it. They'll figure out a way to do whatever they want to do without using the thing that you designed. So, I mean, I heard a few times people say, well, education alone isn't going to solve it. I get it. I'm not proposing that all you do is educate. But I think it's a good first step still, right? But just, being able to articulate that, I think, can be helpful.
All right, thank you.
Thank you.
15-minute break.
Oh, thank you.
We'll start promptly at 1:15 because we have presentations to get through.
Want to start on time. So first, want to thank Dr. Wan for his wonderful presentation. It was very enlightening, and I think you'll see in this next section here, if I can get the clicker to work. If not, we'll just use the mouse. Maybe. Here we go. We're going to have oral presentations from our top two resident and fellow presentations and our top two student presentations. So you're going to see a little bit of that intentionality, you're going to see some of that persuasion, and you're going to see some of the empathy in the work. So just kind of keep an eye out for those things. I'm Nick Clark. I'm a pediatric hospitalist across the street. I also have the luxury of being the medical director for performance improvement, which is our lean healthcare system, as well as the director of our resident and fellow QI improvement education. So again, thank you everyone for being here. I am also representing the QIPS, UMKC QIPS Steering Committee. Our presentations are going to be we're going to start with the two resident fellow presentations, and then move on to the two student presentations. The top two abstracts from each of those submission categories were then selected to present today. They are going to be 10-minute presentations with about 5 minutes of Q&A, plus or minus depending on the presentation duration. So we do ask you hold your questions at the end. And then if there's any time, go ahead and ask them. We'll use the live mic so those in the audience, virtual audience can see us, and then Sari is manning our chat. And so we will go ahead and they can be asked through the chat as well. Moving on to our first set of presentations, we want to say congratulations to doctors. I'm going to try and get it right, Josh. Saucelo, as well as Drs. Fry and Ellsburn for their top two presentations today. So go ahead, and they were the, out of 19 resident fellow presentations, they scored our highest and were deemed worthy of this category. So thank you, everybody. Go ahead, and Josh, come on up.
All right. Hello, everyone. I'm Joshua Saucedo. I'm a second-year pediatric emergency fellow at Children's Mercy. Thank you so much for the opportunity for allowing me to share my fellowship project. It's titled Reducing Antibiotic Duration for Pneumonia and Sinusitis in the Emergency Department, a Quality Improvement Approach. I want to give a big thanks to my large team down there, especially a big shout-out to my mentor, Dr. Elfagali, who mentorship has been invaluable. No disclosures that I have in this presentation. As some background for my project, we have a very robust antimicrobial stewardship program at Children's Mercy, and they were able to provide me with some initial baseline data that showed us that while our ED prescribers did a good job of selecting first-line antibiotics for treatment of disease, duration remained a bit prolonged, especially when compared to our similarly sized pediatric hospitals. So I've included examples here of recent national guideline changes with the Red Book, which was published by the American Academy of Pediatrics Committee on Infectious Disease, that was recently updating its treatment duration for pneumonia down to 5 days for uncomplicated cases. And this was reflected in our own internal guidelines for uncomplicated cases with a 3 to 5 day duration range depending on patient's age. But of course, it allowed for prolongation depending on severity and other factors. Similarly, for sinusitis, the Red Book recently updated their guideline to 5 to 7 day durations for treatment of sinusitis, and this was similarly reflected in our own internal guidelines. So from there, we were able to create our AIM statement, which was to increase the percentage of children discharged home from the emergency department with a diagnosis of pneumonia or sinusitis, treated with an optimal antibiotic duration, which is variable for each disease, from 13% up to 70% by July of 2025. We selected as our outcome metric, the combined was our primary for pneumonia and sinusitis, looking at those receiving optimal durations. And then we had 2 subcategories for our secondary, with each diagnosis receiving its own separate category. In terms of our process metrics, we aim to look at the usage of our EHR order sets and quick discharge order sets, as well as QR code usage for access to our clinical pathway guidelines, as well as our outpatient antibiotic handbook. In terms of our balancing metric, we wanted to check the number of return visits to the ED and urgent care with the same discharge diagnosis within 14 days. In terms of our data collection, we started with the baseline data from August of 2022 through January of 2024. We received this as monthly data. We separated it by diagnosis and then further stratified it by the prescribed duration ranges. Exclusion criteria included patients that did not receive any antibiotics, those with co-infections that required prolonged durations of antibiotics, and those infants younger than 3 months. From there, my team was able to create a fishbone diagram which looked at factors related to the prescriber, those related to the patient and their family, those related to the AHR and our pharmacy, as well as those related to guidelines and ED environment itself. And I've highlighted those areas there that we seem to agree to focus on in terms of when we were making our key driver diagram. And this, of course, led to changes in our interventions that I'll speak on next. So I'll just pause very briefly because we do have a lot to get through in terms of our interventions. So moving on, in terms of the timeline, I've included here the outpatient antibiotic handbook that was updated in August of 2023. This was technically before our team formed, but as we'll see later in our data, it caused a good shift in our data set. So our team formed actually in December of 2023. It included physicians from the emergency department, infectious disease department, as well as our urgent cares, and then advanced practice providers, advanced practice nurses, and then pharmacy team members. From there, in February of 2024, we were actually able to work on the internal guidelines for pneumonia to update it to include the 3 to 5 day duration recommendations. And then in April 2024 is when we started making changes to our EHR in terms of what duration ranges were automatically offered by the order sets. And then in May of 2024, we did similar changes to our quick discharge order sets. In June of 2024, we sent out a survey to our prescribers to both provide them with education and resources as to why these recommendations were being made, as well as seeking their feedback in terms of what interventions they felt might work best for them in the future. From there, we were able to start posting education around the ED workstations in the form of QR codes that linked them to the specific resources that we had previously mentioned, but also included a brief blurb of the overall recommendation. In October of 2024 is when we started sending out kind of quarterly emails. The first one was for provider acknowledgement, sending out encouragement to those who were meeting our goals and encouraging them to do well in the next quarter. In November of 2024 is when we started providing residents with the resources, and these were for rotators in our emergency department would get an email prior to their start with the resources and recommendations for treatment of pneumonia and sinusitis. In December is when we were able to create the sinusitis guidelines in our institution, as well as I was able to write a link article that was disseminated throughout our hospital system and was available to those clinics associated with our hospital to let them know about the recent updates to these guidelines. In January is when we continued our quarterly feedback. However, at this time, we not only provided positive reinforcement of those providers meeting our goals, we also provided constructive criticism and feedback to those not quite meeting the goals, encouraging them to relook at the guidelines and the recommendations and the data kind of backing those up. In February is when we started passing out resident badge buddies. So these were QR codes that residents could put onto their IDs, and it allowed them access to our outpatient antibiotic handbook, as well as our guidelines for pneumonia and sinusitis. Finally, most recently in April, we have started posting our data to the QI huddle boards within the ED, just to get the nurses on board and for them to be our kind of last barrier to discharge before patients left with prolonged durations. In terms of our data, I'll start initially with our primary outcome, and I'll make note that it's annotated with all the interventions that I just mentioned, and then below, next to the month, is listed the number of patients that we saw each month. So as we can see here, we had 2 shifts in our center line. Initially, our baseline data was at 12.8. We are now at 59% in terms of total patients leaving with the appropriate antibiotic duration. So this was for the combined outcome, and as you'll see in the numbers below, pneumonia makes up a large majority. So this is now if it moves, There we go. So this is pneumonia, so it looks very similar. It does take up the majority of the patients that we see each month. In this case, the two center lines kind of changed similar months. This one went up from 13.4% up to 58.5%. And then the two main interventions that we saw this change that we believe led to the changes were the release of the outpatient antibiotic handbook, as well as the update to the EHR order set. This next one is for sinusitis. It's a lot more variable, a lot less cases that we see per month, maybe a handful or two each month. But we can see one center line shift. This data is going from a baseline of 5.1% up to 67.5%, with the main change there being after the outpatient antibiotic handbook has been released. In terms of our process measures, the ones that we have access to right now is our QR code usage for our guidelines. As we can see, it initially started off fairly strong, but then has petered out. We think this is partially due to people using private devices and having guidelines and outpatient antibiotic handbook automatically downloaded onto their device and no longer needed to use the QR code, but also other access points through our internet feeding into those guidelines as well. In terms of our balancing metrics, I've included a G chart here just to show that we've had a very low number of return visits. On average, about 1.3% per month is returning, with our peak occurring actually before the project even started. So no changes that we were seeing there. So in conclusion, we saw a reduction in antibiotic durations for pneumonia and sinusitis with first the publishing of the outpatient antibiotic handbook with the new recommendations, but also with the changes in our EHR order sets and quick discharge order sets. And then we've seen pretty good maintenance in terms of providing prescribers with the education that they asked for during our survey. Our limitations, of course, derive from the number of prescribers in the ED, as well as the variability of the prescriber schedule and the availability of further involvement within the project. In terms of our future interventions, we do have now a list of emails, so we'll be contacting families and providing them surveys, seeing what they thought of the process, what they thought of the care that was provided to their children, and kind of their thoughts after leaving the hospital. There's also other interventions in our mind of further education for residents and our moonlighters. And then one last comment I wanted to make just about the health inequity assessment of our data. We did see a difference in terms of white, non-Hispanic, English-speaking patients with private insurance receiving second and third line antibiotic choices more likely than their peers. But once the antibiotic was chosen, there was virtually no change in the duration that was selected. So no changes in our data that we have collected so far. This is my reference for the Red Book. I'm happy to take any questions.
I think we have time for probably one question. Come on.
It's not a question, it's just wow. That was fantastic. That was a beautiful fishbone diagram, a stunning driver diagram. How many interventions? A dozen? How long has this project been? When did it start?
It started last January, so we're planning on a year and a half of
And is this your first QI project?
Yeah.
Well, I don't know if we have any questions we should ask after that. So thank you, Josh.
Thank you.
All right, next we have Drs. Fry and Drs. Ellsburn.
Hi, I'm Abby Ellsburn, and this is my colleague Jillian Fry. We are second-year Keynote Fellows at Children's Mercy. We have no disclosures to present. For introduction, pediatric HEMONC and BMT patients often require prolonged hospitalizations just by nature of their diagnoses, treatment course, and associated complications that can come with that. As part of that, during a prolonged hospitalization, they're at risk for deconditioning and decreased function secondary to that. Rehab medicine is a field of medicine that's engineered to optimize function in these patients, with oncology rehabilitation being an emerging field with the idea of accompanying these patients throughout their treatment courses from time of diagnosis to throughout treatment to late effects or palliative care. At Children's Mercy, rehab medicine has not been consistently consulted for our patients. What we have seen is of patients admitted to our services, which includes the HEMONC resident team, a chemotherapy team, and our bone marrow transplant team, only about 15% of patients had rehab medicine consults for prolonged admissions between the months of October and November. So our project, to prevent deconditioning and maximize function in these patients, we aimed to increase the percentage of HEMONC and BMT prolonged hospitalizations, which for our definition is a week or longer, with rehab medicine consults from 15% to 40% by February 1st of 2025. So the patients that were evaluated were those that were admitted to our HEMONC resident team, which covers general hematology and oncology patients, our chemotherapy teams, and the bone marrow transplant services. Analysis of the current state demonstrated that educational barriers on the roles of rehab medicine, difficulty on identifying at-risk patients for deconditioning, and inconsistent monitoring of functional status of these patients as possible root causes of our inconsistent consultation. Our first PDSA cycle introduced standardized criteria for rehab medicine consults, which was implemented in January of 2025. Our second PDSA cycle consisted of further education for team members, as well as standardizing documentation of functional status using Lansky and Karnofsky scores, which was implemented in February of 2025. The results of these interventions were then evaluated using run charts. Our outcome measure was the percentage of prolonged hospitalizations with rehab medicine consults in place. Our process measures were then the documentation of functional status using Lansky-Karnofsky scores, and then PT, OT, and speech consults. Our balancing measure was the time from a rehab medicine order being placed to the documentation of their note to make sure that in the process of doing this, we're not putting undue burden on our colleagues with rehab medicine. Our standard criteria were developed with the idea of patients that we know will likely have a prolonged admission at the time of diagnosis or time of admission. This included patients with acute myeloid leukemia or AML that when they're admitted for chemotherapy and then through count recovery, the admission itself is estimated to usually be around a month or so. This also included patients admitted for bone marrow transplant who we know will also have an admission roughly a month in duration. We included other patients that are anticipated to have a stay of 7 days or longer, so a patient with bacteremia or another infection that it requires a prolonged course of inpatient IV antibiotics. And then lastly, we included patients that, when assessing Lansky-Karnofsky scores, have a score less than 70. Lansky-Karnofsky scores are validated measures of functional status for these patients and can identify those patients who then are demonstrating signs of deconditioning. The Lansky score is used for patients less than 16, with Karnofsky scoring used for patients greater than or equal to 16, and the correct form when inputting this into Cerner is automatically identified. We have the driver diagram that then kind of emphasizes some of those barriers that we found, with first being the provider buy-in and awareness of the role of rehab medicine, which has become an increasing thing at Children's Mercy. With us addressing education as well as identifying those patients most at risk. We also hoped that improved communication with families would be addressed with our standardized criteria. Isolation orders or language barriers can sometimes present a barrier to identifying and placing consults, with the idea that the standardized criteria helps address those biases. We also identified access to rehab medicine and resources for them as another potential barrier. However, given the kind of time and duration of this project, this would be something to be explored in a future PDSA cycles and something that we were limited and unable to address in full during the course of our project.
All right, so to get into our results a little bit here, this is our first run chart. So this is looking at the percentage of prolonged hospital stays with a rehabilitation medicine consult. So from October 2024 to December 2024, we were really just gathering some baseline data. So the solid yellow line here shows our baseline of only about 15% of prolonged hospital stays were getting a rehab medicine consult. So our goal was to reach about 40%. So in our first PDSA cycle that occurred at the 1st of January of 2025, where we tried to standardize that criteria for consultation, we did see an increase in the percentage of consults from that baseline of about 15% average to 58%. And then in February, with our second PDSA cycle, where we provided additional education and also tried to standardize the documentation of our functional status with the Lansky and Karnofsky scores, it was still increased at 47%, although we do recognize that it did drop a little bit in the month of February. This is our second run chart, so looking at the percentage of prolonged hospital stays that did have a documented Lansky and Karnofsky score, which was the main aim of our second PDSA cycle. So from October to January, we were really just gathering some baseline data, and the average of that was about 30%. And then once we tried to standardize that, identifying a method in the chart where it was easy to document, as Abby mentioned, we did see an increase to about 63%. So in summary for our results, following our first PDSA cycle, we did see an increase in our outcome measure, or the percentage of prolonged hospitalizations with a rehab medicine consult, from a baseline of about 15% to 58%. Did remain increased following PDSA cycle 2, but did drop off a little bit. And I think that just illustrates to us the importance of continuing education and gentle reminders. Our wonderful residents are the ones usually putting in these consult orders, and they spend about a month on our service before they rotate off. And so making sure that we're educating them when the new ones rotate on would be really important. We also did see an increase in the documentation of our functional status within the EMR to about 63%. As great as it is that there's one spot in Cerner where you can document it, it is still a little clunky, and so we're hopeful with the transition to our new EMR that will be even easier. As far as our balancing measure, looking at the time from the order being placed to the first note being written, it was a range from 0 to 10 days. Most of them, though, were completed within 24 hours, if not the same day, because our rehab medicine colleagues are so great. The slight handful of cases that were longer were really just due to patient-associated barriers. So the patient wasn't available for consult just due to everything else going on, procedures and things like that, or the patient or the family kind of deferring the initial consult. So in conclusion, standardizing consultation criteria did significantly increase our consults for patients with prolonged admissions, hopefully leading to the decreased risk of deconditioning in our target population, although this was not designed to look at that outcome. I think consistent documentation of the functional status does still remain a barrier to really understanding, not only in triggering people to think about consulting rehab medicine, but also showing us how much good it does once they do get that consult and they get that help. We also touched on our future PDSA cycles could target improvement in the documentation of these scores, and then just further research into this emerging field, who most benefits, what other criteria should we include, may help us to improve this collaborative relationship. Here are our references. And we'd like to thank Dr. Joel Thompson from HEMONC and Quality and Safety for being our QI mentor for this project, as well as Dinesh Ratnasingam from Pediatric Rehab Medicine for really helping us to improve our collaborative relationship. And we will take any questions.
Great work. Any questions from the audience? Oh, yes, go ahead.
Hey guys, great job. I'm wondering, how does PT play a role in all this? Is a PT consult automatically on the chart when you have an admission, and do they help with the score evaluation, or is that all up to the team? How's that go?
As far as the Lansky and Karnofsky scoring, that's typically done by the primary oncologist or the resident who's admitting the patient. But rehab medicine does a really great job of saying, hey, you need to consult PT, OT, and so they kind of all work collaboratively. We also did kind of track, too, the number of PT consults without a rehab consult. But.
Okay. Very cool.
One more in the back.
Thank you. A wonderful talk. Thank you, and amazing results. I wondered, and I'm a PhD, not a clinician. After 7 days, how much would function decrease within that time? And when patients come in to see a functional decrease, would you have to examine them at the beginning and determine their score before you start the treatment, and then examine after 7 days and see, okay, there has been a functional decline, let's implement the rehabilitation consultation? Or if you don't see a decline, do you do it anyway?
I think the idea behind this project, and in a perfect world, we would have, prior to initiated this, have had consistent Lansky-Karnofsky scoring. The problem was that it was not documented routinely before we started our project. But part of the idea for Lansky-Karnofsky scoring documentation would be to do it at admission and then on a regular basis. That way you can identify those patients who are showing signs of deconditioning. The 7-day marker was used sort of as just kind of identifying those patients who have had a longer or complicated stay, or patients who are going to be in the hospital for a longer duration of time, such as our patients with AML, to not only address if patients are showing us signs of deconditioning, but then also to try to prevent it from occurring in the first place if we know their course is prolonged or complicated.
Anything online, sorry? Okay. I'm sure both of you have had QI training during residency. How is it different now that you're a fellow? What did you learn this time around?
I think the thing that has been the most helpful about this, and I'm sure Jillian can attest to too, is it's great to have the opportunity to work on projects that are specifically engineered for clinical outcomes in our patient population. And that's been a really helpful component of QI as a fellow.
One more, and I think that'll wrap us up. Thank you.
Really terrific job. Really nice job. Just a background kind of question. Has this been attempted before? And I ask it because the operational definitions had to be really clear. And like we heard from Dr. Wong, fidelity, if something's not even done as it is, to implement a project around it could be really challenging. So I'm really impressed.
I think part of Dr. Ratnasingam had training in oncology rehabilitation, and I don't think that we had someone prior to him coming this summer, I believe, who had as much training as he does, and so I don't think it was as prominent before his arrival, so. Thank you.
Wonderful job with the presentations and with the projects. Again, thank you to everyone on those teams, including the mentors and faculty and units who have helped supported them. We're going to go ahead and move on to our next set of presenters. And much like the fellows, I apologize I didn't clarify this. They're in no particular rank order of who's better or worse. They're all awesome. Same thing for the students. We have our top two student presentations here. We have Dr. Beji and Dr. Bhatti are going to present their team's QI projects. Beji, you're first. Sorry, I should clarify. You're up first.
Hi, everyone. My name's Lauren. I'm a fifth-year medical student here at UMKC, and I'm excited to share with you all my team's project on decreasing urine culture contamination rates in the University Health ED. As an unpaid medical student, unfortunately, no financial disclosures. So starting off with some background on urine cultures, when a patient comes to the ED with symptoms of a UTI or a urinary tract infection, we will order a urine culture to identify what kind of bacteria is growing, and that can also help us tailor which kind of antibiotics would be best suited to treat their infection. We also routinely screen pregnant people for asymptomatic bacteriuria or bacteria in their urine that will need to be treated as well. Collecting this is kind of a difficult process, as simple as it may sound, and it's pretty subject to contamination. If the area is not cleaned properly, skin flora could contaminate, or improper processing technique could contribute to contaminated urine samples. And these could lead to repeat testing. We might need to repeat the urine culture. We might end up sending antibiotics that are unnecessary, and that can contribute to resistance. And all of those can contribute to increased healthcare costs, both as on the system as a whole and on the patient's part. So we looked at all of the departments at UHTMC that collect urine samples, and this is their contamination rates. And as you can see on the far left, the ED had by far the highest rate of contaminated urine cultures, which makes sense because they collect the most samples, followed by UH Women's Care, which also makes sense because they collect samples at every visit. So we decided to focus our efforts on the ED. And the national average, based on current literature and the College of American Pathologists, is 15% for urine culture contamination rates across EDs across the country. Ours for the first 2 quarters of 2024 was 39%, so almost 3 times as high. And therefore, our goal was to get the contamination rate down in the emergency department from 39% down to 15%, the national average, by March 31st of this year, 2025. So we started off with a root cause analysis, and I'm going to show you a pretty overwhelming process map that we created. It has a lot more steps than we initially thought there would be, but this kind of details everything from when the provider places the order for the urine culture to when it's finished being processed in the laboratory. And I've marked with red stars some of the areas that we identified for improvement based on discussions with the stakeholders in the ED and the laboratory, and where they thought we could implement some ideas. Some of those were patient factors, some of those were nursing factors, some of those were lab factors. We also came up with a fishbone diagram, which kind of groups those ideas down into equipment factors, physician factors, patient education, and laboratory factors, and those were pretty consistent with the process map that we had mapped out earlier. And so our 2 main areas that we decided to focus on was increasing the quality and consistency of patient education that patients get in the ED when they're about to collect their urine sample, as well as optimizing the processing of those samples once they get to the laboratory. So from discussions with our stakeholders, since neither my mentor or I obviously work in the ED, we had to get some ideas from improvement from them. And we grouped those into a pick chart, which essentially organizes ideas based on ease of implementation and how reliable they would be if implemented. And we chose 5 to focus on, which are listed here. Our first countermeasure that we implemented was creating instructional posters to go in the ED bathrooms. These were actually designed by my sister, so she's watching from Zoom. Thank you for that. So we did have a couple up in some of the ED bathrooms before this project started, but they were really wordy. They were only in English, and they were pretty hard to follow. So we made some of them, we made them more color-based. We made the explanation shorter, added some pictures, and also put them in English and Spanish, which are our 2 most common languages in the ED here. And we made sure they were in all the bathrooms. Our second intervention was reviewing proper collection techniques with the ER nurses and the techs, and not getting sample from indwelling Foley catheters or bedpans, and making sure that it's a clean midstream catch. And then we also provided them with a sample of explanation that they could give to patients on how to collect the urine samples, or instructions that they could give to patients. Our third intervention was the implementation of urine collection packets, which are essentially a little baggie with the urine collection cup and 2 wipes, which are all the supplies that the patient needs to collect a good urine sample. And those were assembled in the laboratory and then distributed in the emergency department. For our 4th intervention, we moved up to the laboratory, and we reviewed proper urine processing techniques with the lab techs who were processing the urine once it arrived in the lab. And we also put up a poster at the station to kind of remind them of best practice technique there. Our 5th intervention, which we're currently working on, it's pretty technically difficult, but we were hoping to implement a lab mini fridge right next to the pour-off station. Multiple studies have shown that if you get the sample into refrigeration within 30 minutes of collection, it drastically decreases the rate of contamination because it halts the growth of bacteria and gives you a more accurate idea of what bacteria was present when it was actually collected. So we are still working on that one. Here are our results. Our first 2 data points on the top left there were our baseline data points from the first 2 quarters of 2024. They were both at 39%. And then after our first intervention of the ED posters, it decreased pretty quickly down to around 33-34%. However, the nursing education and collection packets either didn't make that much of a change or actually increased the rate of contamination. And I have some ideas coming up here in a second. And then the rate did start to go down after our urine pour-off posters in the laboratory. So just as a quick summary so far, we were aiming to decrease the contamination rate from 39 down to 15%. We did a root cause analysis with our process map and our fishbone, and then used our PIC chart to prioritize countermeasures and implemented those in a series of PDSA or Plan, Do, Study, Act cycles throughout the year, and then track the results from that. So our first PDSA cycle, the ED posters, were pretty effective in reducing the contamination rate. However, subsequent cycles, not as much, not as reliable. With the nursing education, it kind of, I know several speakers have alluded to this before, that education is not quite the most reliable intervention for QIPs, but it's a good place to start, as Dr. Wong mentioned. And so it kind of relies on word of mouth. We did meet at several staff meetings, but as we know, the ED staff rotate in and out. They do a lot of shift work, and so there's a lot of people working in the ED, and it kind of relies on word of mouth to get the information spread, and a QI project probably is not at the top of their priorities for a busy ED shift. So that's probably why that one wasn't as reliable as we thought. The third PDSA cycle, the implementation of the urine collection packets, there was actually a little bit of a miscommunication with that. We had ordered some brand new vacutainer collection systems, and we had been notified that they were delivered a couple months ago, but turns out they actually just got here a couple weeks ago. So the packets that they were using in the ED were the old cups, or the standard cups that they had been using. So we are going to try to implement those new ones in the next couple weeks here, and we're pretty excited about those. They are an aseptic transfer technique, and then the urine collection tubes actually have a preservative in them that will halt the bacterial growth right there. So that eliminates the need for prompt refrigeration and should cut down quite a bit. But as we are predicting, we will need to do a lot more education with the ED staff and the nurses who are collecting it, because that's going to change their workflow quite a bit. And also we need to talk to the lab and make sure that those tubes are okay and how they want it processed. So those are kind of some of our next steps. And then some balancing measures, you can think of these as sort of unintended consequences from the countermeasures that we implemented, would be an increased workload for the laboratory staff who are assembling the kits, and then also an increased time burden for the nurses in the emergency department to explain the process to every patient. So in the future, continuous monitoring, we'll keep making adjustments based on feedback with our stakeholders, and then identifying some project champions in both the laboratory and the ED to keep the project moving forward in the future. These are my references, and then a big thank you to the Rayudu family for your generous support of the QIPS program. We really appreciate it. And then thank you to my whole team, and especially my mentors, Dr. Reddy, Ms. Cantrell, and my faculty mentor, Dr. Galbraith. We kind of learned the QI process together this year, and I couldn't have asked for a better mentor, so thank you so much for your help and guidance. And with that, I'd be happy to take any questions.
Hi, Lauren. Awesome project. So my question for you was, if you looked into contamination rates at hospitals similar to University Health, like safety net hospitals?
Good question. Yeah, so as many of you know, we're an inner city safety net hospital, and so our patient population is pretty underprivileged, under-resourced, and our ED is very chaotic. So a lot of the urine collection factors could be patient-related. And so we did actually look into that, some of the safety net hospitals across the country, and I wasn't able to find a great average, but some of the studies suggested that it was up to 55% contamination rate. So if that's the case, our hospital is actually doing pretty well with 39%, but we'll continue to work on getting it down. So good question, thanks.
For the decrease that you saw when you implemented the nursing staff changes, it wasn't a huge decrease from 39 to 34, right?
Yeah, not huge.
It wasn't huge, but it's there, yeah. So how much of a difference in time or was it that you put on the nurses to have to, change what they were doing previously to what they were currently doing with patients? You'd imagine every patient must be told first exactly how to do it before they do it, how they collect the sample. Mm-hmm. So I don't understand why it was so much more time for the nursing staff to explain to the patient.
Yeah, that's a good question. You mean like how much time would it take to explain to the patient? Yeah, so the script that we gave them was a couple sentences, just explaining to like cleanse the area with 1 wipe and 2 wipes, and then this may be a little TMI for you, but pee a little bit into the toilet and then collect the midstream catch and then try to close it without touching the inside of the container. So maybe 15 to 20 seconds, but it is a lot of mental burden for the nurses because they're thinking about so much, they have so much on their plate. Trying to remember to hit all those points with every patient probably contributed a little bit. I think, like I mentioned, the staff turnover is pretty significant as well, because nursing shift happens every 12 hours or so, so trying to make sure all the nursing staff that rotate through are educated as well.
So a comment and a question. So my first comment was there was a question earlier around, well, how can we start taking equity-based approaches? And I thought your example of printing out patient instructions in 2 different languages based on the most prevalent languages in your community is a nice example of how you accounted for different needs, so congratulations. My question is really around, a lot of times quality improvement work have like co-benefits for the project team members in terms of just learning about things within the system that were surprised you. What surprised you about the way emergency room departments work that, you thought, gosh, as a student, you're new to the system, like, why is it done that way? And how can you help us think about how we can improve the system in different ways based on what you observed in your project?
Yeah, I had very little experience in the emergency department before this project, so I spent a lot of time down there trying to observe and talk to the techs and the nurses and figure out how these things were going. And the main thing that I gathered was that there wasn't really a standardized way of instructing patients. Like some nurses I talked to would go through the full script. Some would just say, oh yeah, we just hand them a cup and say, give us some urine. So I think just having a better comprehensive way to make sure everyone's on the same page about instructions and making sure that patients are consistently getting the same instructions would be helpful.
Great. It's a great illustration of work is described versus work is done, right?
Mm-hmm.
Yeah. Great. Thank you.
Thank you. We probably have time for one more.
Really nice job, Lauren. I love how you narrate the project. Like, it's more about what you learned than if the gap was closed. So you did a really nice job with that. So don't worry too much about that one blip, and it's the 6th point in a row, so you might actually see it in the next one. My question for you, with you and Dr. Galbraith not being emergency department staff at all, and you going to them with this project, I was curious, with the number of different interventions you brainstormed, did you brainstorm those with the ED? And how did you choose the ones that involved the ED more than the lab?
Yeah, so we did. We asked, when I went down there to kind of evaluate the process, I asked them, what do you think the problems are? And then how do you think we could improve it? Like, what are your ideas? And so we compiled a list of those and then organized them into that pick chart based on cost efficiency and ease of reliability and things like that. So that's how we did that. And it seemed to be that the majority of the problem was in the ED. The lab has a pretty good process set in place already. There were just a couple minor tweaks, like amount of time that the urine sample was sitting outside of the fridge and ensuring that the pour-off process was as aseptic as possible. So we decided to focus more on the ED and then a little bit in the lab at the end. Yeah.
Great, thank you.
Thank you.
All right, moving on to our next and final presentation. We have Dr. Bhatia. Student doctor, almost doctor.
Okay, hello everyone. Thank you so much for this opportunity to share my project. I worked with Dr. Thompson on this project through the QUIPS program. It's titled Increasing Guideline-Based Antiemetic Prophylaxis for Chemotherapy-Induced Nausea and Vomiting Within a Tertiary Pediatric Hospital. I have no disclosures or conflicts of interest. So just for a background, chemotherapy-induced nausea and vomiting is an issue many patients face. It can lead to decreased quality of life and malnutrition for patients, but also from a healthcare standpoint, it leads to increased hospitalizations and further hospital costs. And I'll be referring to these levels throughout my presentation. So just to give you an overview, the way we classify immunogenic potential is kind of like 4 tiers. So minimal is 0 to less than 10% of patients experiencing emesis. Low or LEC is 10 to 30%. Moderate or MEC is greater than 30 to 90%. And then high or HEC is greater than 90%. So we evaluated this issue internationally, and that baseline was around 46%. And then we looked at Children's Mercy, the site of our project, and that was a little bit higher at 49.84%. Ideally, concordance should be around 90%, as you can see in HEC as well, with that 10% accounting for any allergies or intolerances, but 90% is pretty high up there from where we're at. So our aim statement was our project aimed to increase the percentage of chemotherapy episodes, including low, moderately, or highly immunogenic chemotherapy with CPG, or clinical practice guideline, concordant antiemetic prophylaxis in pediatric patients from 49.84%, our baseline, to greater than 67% by March 1st of this year. So we first started out by just looking at the problem. I had the chance to visit the site several times, and I started out by just mapping out the process to grasp the issue. And this was very important during our entire project, the fault tree, because it really broke down the issue into several different routes. So there's route of administration, there's location, and there's immunogenicity. As you can see, the one circled in red, intrathecal chemotherapy is the biggest gap. It was at 17% concordance. And in immunogenicity, you can see that MEC is around 29%, the lowest there. It's important to note that a lot of the moderately immunogenic chemotherapy was actually intrathecal chemotherapy, which may be contributing to that decrease as well. And then we also formed a fishbone diagram. So our team, we formed a multidisciplinary team with nurses, physicians, myself, QI leaders, and pharmacists within the pediatric oncology division. And we met about bi-weekly and talked about our project. And the first meeting, we really used this fishbone diagram to break down the issue. And as you can see, the ones in red, historical practice, guideline clarity, and guideline availability, were the ones that most people felt were ones that we needed to target first. And so using that fishbone diagram, we then created a pick chart to analyze the payoff and difficulty of possible interventions. And so those in blue stars were those that we wanted to tackle first, then the ones in purple second, and then third were the green stars. And so that brings me into the interventions that we implemented. Our first one was in October. That was primarily education for intrathecal chemotherapy. As I said, that was the largest gap that we noticed. So we provided education about this at the oncology division meeting. And then in November, we talked about palonosetron monotherapy. Palonosetron is an antiemetic that's commonly used, and some recent research has actually indicated that we can use it as a monotherapy agent. So we provided some background about that at another division meeting, and we also discussed some of the results that we've been seeing so far. Then in December, we updated our EMR, which was Cerner at the time, to allow for intrathecal chemo pre-check for certain order sets. And then at the end of December, we re-emphasized the palonosetron monotherapy. And then we also discussed, compared to November, whenever we first discussed that, we showed the results as to how that was being implemented. And then in February, we tackled one of our difficult ones, which was a pharmacy feedback system for intrathecal chemotherapy. And then lastly, in March, throughout our project, we were working to revise the guidelines. Some of them were out of date, so we just needed to update them, and then we made it a little more concise, so everything was visible on one page, and then you could use flow charts or like diagrams if you needed more clarification. So we uploaded those to the provider portal. And that brings me to our results. So throughout talking about the results, I just want to clarify some terms that I'll be using. So special cause and common cause variation. Special cause variation is essentially, it's describing that it's not due to the process itself inherently. It could be potentially due to some of the implementations that we chose. So our results, or outcome measure, was the percent of CPG concordant care. And that was found to be of special cause variation. We ultimately shifted our center line from 50% to 69% at the end of our project. Our process measure was the percent of under prophylaxis and intrathecal chemotherapy, and we were able to decrease that from 83% to 40%. And that was also special cause variation. And then common cause variation is something that essentially is saying it's due to the inherent nature of the system, not necessarily what we're implementing. And our balancing measure was found to be of common cause variation, and that was the percent of HEC, MEC, and LEC and minimal over prophylaxis. And that center line stayed consistent at 10%, as we hoped for. So in summary, if this works, there we go. We implemented 5 PDSA cycles, and we had a multidisciplinary team that was very essential in this process. And we ultimately were able to increase our concordance from our baseline at 49.84% concordance to 69%. And then our process measure, intrathecal chemotherapy, was able to increase in concordance significantly by almost triple. In conclusion, we did identify several barriers. First of all, physician experiences differ significantly, which did result in some skepticism, such as implementing the palonositron monotherapy. Our EMR at the time was Cerner, and if you guys don't know, we're switching to Epic for CMH. So it was a little difficult to really change all of the pre-check order sets, so we were only limited to a select few. Moving forward, these abnormalities will continue to be visible. We'll continue to analyze our data on a biweekly basis and display that in run charts. And honestly, one of the things that I learned during this project was discussion about the issue itself was really important, just bringing awareness, and that's going to continue to be emphasized. And embedding improvement. So I did mention one of our barriers was technology, but it's also an opportunity for improvement. Because we are switching to Epic, this project really emphasized that pre-checks can make a huge difference in clinical practice. So that's something that's being embedded into the new power plans. And then something that we worked on throughout our project were guidelines. So we'll continue to edit those guidelines to be up to date, concise, and easy to access. This was my baseline for the international baseline. And some credits and acknowledgements. So my faculty mentor was Dr. Joel Thompson. It would not have been possible without him, so I am very thankful for all his support. And then our multidisciplinary team was essential in this process, and they are the ones who are going to keep carrying this project forward. And thank you to the entire pediatric oncology department at Children's Mercy for really engaging in this process. And Dr. Mamta Reddy and Ms. Sari Contrell for giving me this opportunity, and then the Rayudu family. This has truly been an influential experience. So thank you.
I knew if I waited long enough.
Hi, I'm one of the HEMONC fellows / attendings who's been listening to your chats and presentations on this in our division meetings. I just wanted to make a comment that I have always been a big proponent of palonositron, but I think also what part of it has been is some education to the families, because this drug is nice in the fact that it lasts 48 hours compared to the standard Zofran that we were using ahead of time that they may have to redose once they get home. And so it also decreases, hopefully, the amount of medications that they're trying to keep up with at home post intrathecal chemotherapy or whatever they've given in clinic. And so hopefully it improves not only our adherence with the guidelines, but also the patient experience as well.
Other questions? I was going to ask one, but Mamta, go ahead.
Really nice job, Mira. That's a really high-level project. To that point, did you get any input from patients?
So I actually had the opportunity to do a whole month-long elective on the Peds Oncology division. So throughout my project, I didn't specifically say, hey, I'm doing a research project, but I gauged like the antiemetic prophylaxis that they were getting. I was very interested in the orders that were happening. But we didn't necessarily really focus on the patient satisfaction as much, but we did talk a lot to physicians and providers about their experiences.
When you came into the project, what did you think the answer was going to be before you had the information?
Yeah, that's a good question. Whenever I came into the project, I did jump to conclusions, to be completely honest. And I was like, it's the EMR, we need to fix Cerner. And that's not true. A lot of it was just increasing awareness, discussing the project in general. The EMR is a tool, it's not the answer to everything.
And then when you came to the fault tree, which I appreciate you doing, I think it tells a very different story than other data can tell sometimes. And so I like slicing the data in multiple ways, process maps, Pareto's, fault trees, you name it. Is the more you can do, I think the better you can understand your system. Were you surprised when you saw those results?
So to be completely honest, I didn't have a lot of education about the different routes that you could take for chemotherapy and also antiemetic prophylaxis. So originally I didn't really know much about it, but as I talked to Dr. Thompson and the different nurses, pharmacists, providers about the chemotherapy options, then it kind of made sense. Intrathecal chemotherapy is one that maybe a lot of people aren't familiar with too.
Great, thank you. What other questions? When you came in to present to the HEMONC group, was you presented, or was it Dr. Thompson?
It was me.
Okay, great. So you're an outsider coming in, similar to the other project, outsider coming into the ED, coming into the lion's den a little bit of sorts, right? You have people that are very particular. I am very particular in my ways when I take care of patients, right? How did that feel? How did you prepare? What elevator pitch did you prep with?
Every provider has a very unique experience, which is completely understandable, but also every patient has their unique experience, I think. And so you can't necessarily just decide we're not going to give a patient antiemetic prophylaxis because you may not know what they can tolerate. So I think presenting the data that we had, that baseline, was a big wake-up call for a lot of the providers. And I remember talking to a lot of them after, and they straight up told me we didn't know that was an issue. We didn't know that there was that big of a gap. So just bringing awareness was the biggest thing.
Great. You think about that ADCAR model of behavioral change, right? Awareness is number one. You gotta start there. Perfect. All right. Well, thank you so much.
Thank you.
Well, that concludes all of our presentations. I'm going to pass it over to Dr. Reddy. But first, a big thank you to everyone here for coming to see our presenters, everyone who was a judge, anyone who has mentored or impacted the work in any way, of course. Vijay's family, thank you so much for support of this work. We can't do it without you, as well as Dr. Wong. And so thank you, everyone, for being here. I'm going to pass it over to Dr. Reddy.
You know why I asked Nick to do that, right? So we're going to go right into our next section. So we can take a little break and exit folks from this room for the advisory committee meeting. So I'm going to present for about the next 30 minutes or so various different awards and recognitions. So it's going to look something like this. So we're going to review some highlights of the poster showcase that features the abstracts that were submitted in the student category and in the resident and fellow category that you may not have seen because you were in one room and there were 4 concurrent rooms of posters going on. So we want you to have the opportunity to be able to look at the others as well afterwards. We want to recognize the top abstracts and in the poster competition winners in each category. So that's a highlight that I'm sure some of you are in suspense for. We want to spend some time recognizing the faculty judges who support this important work. It wouldn't be possible without the small army of faculty who volunteer their time to do that work. I want to congratulate the graduating cohort of QUIPS scholars and introduce you to the rising cohort of QUIPS scholars. And then we want to recognize the QUIPS Faculty Mentor of the Year. Then we'll close with some final reflections from the Rayudu family. So this forum invites abstract submissions from teams that are conducting projects that address system issues impacting healthcare, quality, and safety. So projects will typically fall into these two categories: the big safety category that is something to do with harm, and then the other quality projects that are impacting clinical effectiveness, workflow efficiency, health equity, patient-centeredness, and timeliness. But it's these action words that delineate the difference between the intent of QI versus the intent of research. So all QUIPS projects utilize improvement methodology or patient safety science to implement and evaluate innovative or evidence-based change ideas. So the goal is to change something in our current system. So this forum uses an abstract scoring rubric that elevates those efforts that do three things: that define a gap using numeric language, projects that implement at least 2 experiments to close that gap, and projects that graphically display data in time series to represent continuous improvement. So if you're new to QI methodology, I would encourage you to explore the QUIPS LibGuide to learn more. So this year, this forum received 44 abstracts total, and these tallied 263 individual contributors from 11 academic departments. So that's very impressive. The growth in not just a few different departments who have the resources to do QI work, but a lot of these smaller departments. I mean, you note the other because we didn't offer it as an option. So it's nice to see the breadth of involvement. So this forum can now boast a total of 484 unique project abstracts since it was established in 2014. And each year, we see an increase in the number of projects that introduce at least one intervention that's aimed at improving an institution-specific process, problem, or program. So with that, I'd like to ask Sari to come show you how to access the virtual poster showcase.
Okay, so this is my little bit here. All right, so you get to watch me typing, so you can go to Google and type in the Vijay Babu Rayudu Quality and Safety Day, and that will bring you right to our event website. And every year we upload all of the posters that are presented at this forum. We upload them to the event website, and you can all view them here. So if you're interested in past years, you can look at those too, but 2025 is already loaded. And you can see residents and fellows as well as student projects, and any of the posters you can click on and view their poster. And it'll just come right up, and you can peruse these on your own. Again, and you couldn't be in 5 rooms at once, but we want to give you all the opportunity to see all of the great work that was submitted to the event every year. So that's all I've got.
All right, thank you, Sari. So just from that display, you can see the tremendous amount of work that's gone into creating these posters, uploading these posters, studying these posters from 44 individuals, and 4 of whom you have heard from here in this room. So next, I'd like to show all of you who presented either an oral presentation or a poster presentation
this morning, you can claim credit for your work on your CV, I hope, by citing your abstract using this format. I've provided an example here, and you'll have access to this later. Okay, so next, I'd like to invite Priya Patel to join me in announcing this year's poster presentation winners in the student abstract category. For those of you who don't know Priya, she earned top honors as a platform presenter at the 2024 Quips Day event. And since then, yes, you're going to stand here and be uncomfortable while I talk about you. Since then, she's gone on to present her work at both regional and national conferences, including an oral presentation at the Infectious Disease Symposium at Washington University and a poster presentation at the Institute for Healthcare Improvement's National Conference. Her manuscript is currently under review at BMJ Open Quality. As one of 8 students in the second cohort of the Quips Student Scholars Program, Priya successfully completed the requirements to earn the commendation titled Distinction in Healthcare Quality and Patient Safety. After graduation next week, Priya will complete a preliminary year in internal medicine at St. Luke's Hospital. You're welcome. And after which she plans to apply for a dermatology residency.
Thank you for the very kind introduction, Dr. Reddy. So it is with honor that I congratulate Madeline Glodowski and Audrey Otwell. That's okay. Okay. Madeline's team presented a project titled Reducing Rates of Perioperative Hypothermia at St. Luke's Hospital, Kansas City. And Audrey's team presented a project titled Decreased Turnaround Time of Pharmacogenetic Testing in a Highly Specialized Precision Medicine Clinic at Children's Mercy Hospital. Congratulations to Madeline and Audrey, your project mentors and your project collaborators for this honor.
Can you both please stand? Audrey and Madeline, can we just see you? Just stand. Sorry. Nice job. Next, I'd like to invite Dr. David Safley, who is the chair of the Quips Consortium Advisory Committee. He concludes his 2-year term this year at this meeting, and I'd like your help in announcing this year's poster presentation winners in the resident and fellow abstract category.
Thought you were going to say a bunch of nice things about me, too.
Later.
So I am pleased to congratulate Dr. Sonali Ramesh and Dr. Germaine Harriet Romuald. Dr. Ramesh's team presented a project entitled Improving Discharge Documentation Efficiency for Patients Seen by APRNs at a Tertiary Pediatric Emergency Department, and Dr. Romuald team presented a project entitled Utilizing Neonatal Pain and Sedation Score, NPASS, as an objective tool for weaning and escalating sedative medications in neonatal patients. Congratulations to you both, your project mentors, and your collaborators for this honor. Congratulations.
Please stand. Are you here?
I know
Oh.
Dr. Ramesh is on the Zoom.
Okay, very good.
I'm not sure.
All right, congratulations. All right, so the purpose of this forum is to celebrate all of our learners who engage and excel in Quips scholarship. Today, I want to take a moment to applaud the leadership displayed by our faculty mentors as learners and leaders. To this end, I want to talk about 5 key traits and behaviors of exemplary quality, of the exemplary quality and safety leader. So I list integrity and ethical leadership. So they always act in alignment with ethical principles and organizational values, build trust by doing the right thing, even when it's difficult. A commitment to a culture of safety. So they're prioritizing psychological safety and encouraging reporting of errors without fear of punishment, and promoting transparency and continuous learning from adverse events. Accountability and ownership. They take responsibility for outcomes and hold others to the same high standards they hold themselves. They lead by example and follow through on commitments. effective communication and team empowerment. They communicate clearly, listen actively, and foster open dialogue. They engage and empower interdisciplinary teams in decision-making and problem-solving. Vision and strategic thinking. They see the big picture and connect quality and safety efforts to organizational goals. They anticipate risks and lead proactively using data-driven ideas. So we talk a lot about how leadership is encompassed in a QI project. So we've talked a lot over the last year with the current scholars about what it means to be a QUIPS leader. And I'm going to highlight these for the others who haven't heard them or for those who will be hearing them soon, as early as next week. So the first behavior of a QUIPS leader is to ask the right questions and to apply that scientific method to deeply understand a problem before ever beginning to try to solve that problem. Speaking up on behalf of the Institute of Medicine's 6 national aims, which are patient-centeredness, safety, effectiveness, efficiency, timeliness, and equity. And then finally, they relentlessly seek out and eliminate waste to increase value and reduce harm. So what we've noticed over the years is not just the projects, but the mentors that have to be engaged in order to elevate and work with those projects, especially at the student level. So this program wouldn't be possible with the vast number of faculty who get involved. So this is kind of a proxy metric for the engagement at the faculty level, but over the years, we've seen a steady increase and sustaining of the faculty volunteer engagement that we get from across the different hospitals. So I just wanted to point that out, that the faculty in the room are what make this program run. So thank you to our faculty volunteers who participated in first round abstract judging. We had a record of 54 faculty volunteers this year, 9 second round abstract judges, and 15 poster session judges, and we couldn't have done this day without you. So can I have a round of applause for the faculty mentors who make this possible. All right, so next topic, I want to introduce you to the incoming cohort of the QUIPS faculty scholars. Would you all please stand? So the program officially launches this week with the QUIPS student elective and the workshop that we will all immerse in next week. But these 6 have done tremendous amount of work already just to even come up with the right project idea. Several of you have gone through several iterations of those ideas to get to this week and be able to participate next week. So next, I want to introduce you to this incoming cohort of QUIPS student scholars. Would you all please stand? So this isn't a typical elective, so I'm sure you've already seen that this isn't going to be just a reading elective, that we're not going to look at what you've read. So you're going to do some actual hard work. You've already started, and there's more work to come, but we always say this, the projects that end up with the best outcomes do a lot of work this month, so we'll be looking forward to seeing what you do in the coming few weeks. Thank you. Okay. Next, I want to congratulate the graduating cohort of QUIPS faculty scholars. Would you all please stand? So as you all stand, those of you who were able to attend poster sessions this morning, you saw a lot of excellent work. So I want you to be sure to be thanking your faculty mentors for the work that they do with you. And I see flowers in the room. Did the mentors give their students flowers? Oh, okay. Got it. It's coming. All right, thank you. You all can sit. And I have certificates for you and want to take photos after this session, so please don't run off until we do that. Next, I want to congratulate the graduating cohort of QUIP's student scholars. Will you all please stand? Excellent. We have certificates for you as well, so please stick around as well. All right, thank you. Okay, so as you know, there have been 3 cohorts of QUIP's faculty and student scholars, and so depending on what year they were, some even leave after that year to go do a year away, so they're not all graduating at the same time. So this year, we will be congratulating 6 graduating students from the past 3 cohorts of student scholars who have earned the QUIPS commendation that we call Distinction in Healthcare Quality and Patient Safety, and they'll be recognized at the hooding ceremony on May 15th. I'm going to give Audrey the stage. She has some words she'd like to share.
Good afternoon, everybody. My name is Audrey Otwell, and I would just like to talk about my experience as a QUIP scholar who's graduating this year. As I have been able to reflect on my time in the QUIP Scholars Program at UMKC, I can honestly say that it's been a very career-defining experience. It's given me a lot more than just a foundation in quality improvement. It's also given me the tools, the confidence, and the perspective to carry patient safety forward in the next chapter as I go on to a career in pediatrics. I'm especially grateful and thoughtful for the thoughtful mentorship and structured support that helped guide me through each phase, especially when our project did change direction and things were slightly uncertain for a time. But working alongside a mentor like Dr. Pagano, who was also growing in this space, gave me that unique opportunity for shared learning. And I will always appreciate the trust and patience that Dr. Pagano extended to me. And to anybody that's just starting this journey out, trust the process, invest early like we've been talking about, and look to your environment and the people around you as they hold more answers than you may think. And I want to say very much thank you to the QUIP Scholars team, not for just shaping the project and for everything that they do to pay it forward to our patients. Thank you all.
Gonna make me emotional. All right, thank you, Audrey. So I'm so pleased by just the story that all 6 of you have been able to tell in this journey you've had over the last year and a half, some of you 2 years, with the projects that have even continued beyond your time. And it's just been a pleasure to work with you and to watch you grow your problem-solving skills. And we wish you the best of luck as you embark on your next adventures as QUIP's leaders, leading the change to sustain today's healthcare system for tomorrow. All right. So we heard 4 presentations this afternoon, and these were the top abstracts in the resident and fellow category. Joshua and Abby and Jillian, could you please stand? Thank you. Excellent job. And we saw 2 student presentations. Lauren and Mira, will you please stand? And Mira, can you come join me?
Hi, everyone. Nice to see you up here again. My name's Mira, and I'd like to tell you a little bit about my experience working with a QUIPS faculty scholar. The QUIPS program offers a uniquely valuable experience pairing students with faculty who are not only experts in quality improvement, but also deeply committed mentors. My faculty mentor went above and beyond to provide support, foster independence, and ensure I was meaningfully involved, making this one of the most impactful experiences that I have had thus far in my medical training. Through this program, I gained lasting skills, confidence in leading QI projects, and clarity about the kind of physician that I aspire to be. And I'm so honored to have this opportunity to tell you that my mentor is so very deserving of the QUIPS Faculty Mentor of the Year Award.
So, Joel, would you please stand? I was going to do a reveal, but Mira stole that from me. It's my honor to present the QUIPS Faculty Mentor of the Year Award. This year, I'm pleased to recognize a colleague who mentored not one, but two of the presentations you heard on the platform this afternoon, one from the student category and one from the resident and fellow category. This mentor is a part of the current cohort of the QUIPS Faculty Scholars, who serves as the co-medical director for quality and safety at Children's Mercy and the director of quality and safety for the Division of Pediatric Hem/Onc and BMT. For your outstanding service, not only to Children's Mercy, but for your dedication to the UMKC QUIPS program, it's my honor to present to you this year's QUIPS Faculty Mentor of the Year Award. Please don't run off. We have a certificate and a photo we'd like to have at the end of this. Thanks, Joel. Next, I'd like to invite Priya back here to say some words. I've already told you about Priya.
Hello, everybody, again. My name is Priya Patel, and I would like to tell you about my experience working with my QUIPS faculty mentor. Working with my faculty mentor has been a transformative experience. My mentor fostered an environment where curiosity and questioning were encouraged, teaching me to look beyond conventional approaches to solving problems. This mentorship experience has been a cornerstone for my developmental understanding of improvement science, equipping me with confidence and excitement to continue the mission of improving the future of healthcare.
Priya's going to let me do the reveal. Very good. So yes, this year we have a second Faculty Mentor Award. It's my honor to present the second award to a colleague who has continued to mentor QUIPS efforts beyond her tenure in the second cohort of the QUIPS Faculty Scholars Program. In the true spirit of continuous improvement, she's supporting the consortium's journey to build a QUIPS student mentoring program, living the mindset of experimentation, not only in the technical design of her QI projects, but also in the mechanics of her coaching acumen. She has demonstrated outstanding leadership in creating invaluable scholarly experiences for students during her voluntary administrative time while balancing a full load otherwise, making the work of scholarship count twice and sometimes 3 times. For exemplary mentorship, modeling QUIPS leadership to the future leaders of tomorrow's healthcare system. It's my honor to present the second QUIPS Faculty Mentor of the Year Award to Dr. Kathleen Spears. Could you please stand? All right. Okay. Okay, I have a final little pitch. I presented this a couple of years ago, but I wanted to bring it back because it's a program that continues to live on, and many of you in the room have been involved. So when we talk about the awareness that arises by paying attention on purpose in the present moment, we're talking about mindfulness. And the connection between mindfulness and patient safety is very clear. So we have a program here at the medical school called the Mindfulness in Medicine Scholars Program that's doing something very similar. It's a 10-month extracurricular practice-focused program with a cohort of 5 to 15 students each year who meet monthly and not just learn, but practice mindfulness, and hopefully they will be our future chief wellness officers. And this is the graduating cohort this year. So, all right. Now, as we wrap up, I'd like to ask Ranga, Dr. Rayudu, to come provide your reflections of the day.
Hello, everybody. Thank you so much. I just want to say thank you on behalf of the family to all of the students, the mentors. You guys really had some great projects this year. Having observed this over, a 10-year period, you can see that there are considerable improvements in your willingness to tackle the system, which I think is a major, a major opportunity. and I see that the students this year have been willing to engage with all the teams in the ED, the rehab teams, the PT teams, everybody. So, and the quality of some of the questions that were asked are also, I think, broader. There's a lot of opportunity to provide a lot of improvement for, or a lot of, change a lot of the problems with.
Say the word improvement.
Yeah, exactly. Maybe I should avoid that. To create better clinical outcomes for all of our patients, and we're really happy about that. On behalf of myself, my sister who isn't here, my mom and my dad, thank you so much. And yeah, we'll hope to see you next year. Okay.
Thank you, Ranga. Final few notes, and we'll close. Thank you, Dr. Wong, for an outstanding presentation. You met us exactly where we are to give us something to grow with, so thank you very much. Thank you, Dr. Clark, for outstanding job in moderating the platform presentation section. Not only started and ended on time, but there was excellent dialogue. Thank you. Thank you to the QUIPS Consortium's Advisory Committee, its representation across all of our affiliates, and the engagement from our School of Medicine leadership that makes this program so successful. And thank you to the learners who participate in that and engage with that too. So following this, we'll have our advisory committee meeting. So those of you online will need to log on to a new Zoom link. But those of you in the room can stay here in this room. I want to thank Dr. Safley again for an outstanding 2 years. Just a really fantastic partner to work with, and we always feel supported by your chair role. Thank you. I'd like to welcome our new advisory committee chair, Lisa Rao, who will start her term in the fall, at the fall meeting, and continue for 2 years. So thank you for taking that on. And last but not least, I have to thank Sari Cantrell for her just diligent work year-round, but especially over the last few months. I always make it a point to tell people she is the logistical mastermind behind everything that happens, and this definitely wouldn't be possible without you. So thank you. And finally, I have the save the date. We have our keynote guest presenter, Dr. Angela Tuss from Harvard Medical School next year. And so please save the date for Friday, May 1st. And that concludes the program. And we'll have a 15-minute break before the advisory committee. Anyone we had stand or that was mentioned in my last 30 minutes, please stay after for a photo and to receive your certificate. And if the rest of you can make space for them, so we can get that done in 15 minutes. We have 15 minutes left. Yes. All right. Thank you so much, everyone. This is a wonderful day, and I appreciate all of you for being a part of it. Yeah. Oh, yeah, the main.